Thanks very much, and thanks to Amanda and everyone for the invitation. So delighted to be here. And just like others said earlier, it's great to listen to so many people and the different interests that they have. And I suppose one of the things Amanda did ask me to talk about was some interdisciplinary work. And I think, talking about or listening to sociologists and psychologists, that's really great to hear. And I'm going to talk a little bit about that in our study as well. So I suppose just in terms of discipline, so my background is nutrition, so I'm a registered public health nutritionist, but most of my work, if I can work in that area, I do. But I work primarily in child and adolescent health, and then try and focus on nutrition, particularly food environments, and how that impacts, I suppose, access to food for young people. So what I'm going to talk about today, so all the photos I have today are either my children or their friends, and I have obviously permission to use them. And I'm going to be talking about mostly the health behaviour in school-aged children study, really to talk about, I suppose, interdisciplinary working, but also how have we impacted policy. So this won't necessarily refer to body image per se, but I still think some of the examples and what we've done to affect policy change will be very relevant. So hopefully you will find it of interest. So I'll talk a bit about the network, how it's grown, some of the opportunities and challenges I guess we've experienced, a bit about knowledge translation, and then I'll touch a little bit at the end on body image, so the item that we do have in the HBSC study. So really open, as Andras said earlier when he was presenting his flash talk, very open to collaboration and working with others in this area. So what is the Health Behaviour in School-Aged Children study? So it's a WHO, so World Health Organization collaborative project. And really it's been, the network has been studying adolescent health since 1983-84, so it's established a long time. And we currently have 51 countries and or regions involved, and there's over 450 network researchers. So, and these researchers are from a vast range of disciplines. So whether that's like nutritionists, psychologists, sociologists, epidemiologists, a range of different expertise and backgrounds and ways of working, I suppose. But for the HBSC survey, it's a school-based survey, and we used, I suppose, a consistent research protocol. So a standard methodology is used, and that actually ensures, I suppose, that we have confidence and have good quality data. So that's important as well when we're looking to disseminate our research, but also getting others to come to us as well. So it's a cluster sampling approach, and to be part of what's the international data file, each country needs to collect at least 1,500, or collect data from at least 1,500 students, age 11, 13 and 15 years of age. And this is a time, obviously, 11-year-olds is probably the onset of adolescence, 13-year-olds, a lot of physical, emotional changes, and 15-year-olds starting to think about subject choices and what they're going to do with their lives. So obviously, earlier people were talking about developmental change, so significant change over those time periods. So just to note, I suppose the most recent data collection, well certainly in Ireland, but across the network was in 2021-22, and we have over 280,000 young people from across the network. So really large data set, which gives us, I suppose, a lot of opportunity to explore different aspects of child and adolescent health, of one, which is body image. So I'm just giving a bit of background around the network, because it might help in terms of trying to develop, the network, the body image research network. So it started, I suppose, in 3 countries. So that was Finland, England, and Norway. And it was based around a tobacco conference, actually. But since then, they started to collect data. Originally it was every 2 years, and then moved to every 4 years because of the funding and, resource challenges, I guess. And then setting up a more, I suppose, embedded partnership with the World Health Organization. And that has been instrumental, I suppose, in how we disseminate and who we get our message to. So we work with the World Health Organization, but particularly the European office. But obviously with their links with UNICEF and other organisations, we also link with a lot of other organisations that are working with young people. So now we have 51 countries in Europe, Central Asia and North America involved. This is just a flavour of the countries. I suppose just to say, in Ireland, we only collect data in the Republic of Ireland. Northern Ireland aren't involved at the moment. They have a youth survey themselves, but I know there's some people here from Northern Ireland, so maybe we can talk a little bit about that as well. These are the opportunities for doing that. So what are the aims of the study? I suppose the idea is obviously we want to collect this cross-national comparable data, so having our high quality data is really important here. We want to ensure it's reliable and it's valid. Gather that cross-national data, and I suppose underpinning that to advance the scientific field of adolescent health. So lots of people have talked about, I suppose, determinants of health, social contexts of health, health outcomes. And we're interested in that for child and adolescent health around a range of topics. So that might be things like, yes, what their risk behaviours, smoking, drinking, what they're eating, how physically active they are, the type of activities they're involved in, but also the social context of health, so their schools, their families, etc. And then the broader context as well. So trying to understand how these settings or the areas that they're living, they're working and they're playing, how that's impacting their health. Obviously, we want to encourage the use of data in policy and practice, and I'll come on to that when we talk a little bit about knowledge translation and what we do in our approach, I guess. Building capacity, and this is probably something as well with your network, building research capacity. So we would have an early career group as well. An early careers group. So building capacity so they can develop and lead the network in the future. And in terms of collaborating with partners, as I said, we have WHO, but obviously working with other organisations like UNICEF. But we also work, within our countries. We work locally, regionally, nationally with community groups, with schools, with parents' organisations, with principal networks, charity groups as well. And actually our work with a lot of the charity and community groups, they have the experience of disseminating and getting the knowledge out there as well. So a sort of a partnership approach has worked really well, I think. So as I said, we did start looking at risky behaviours like smoking, and then moved it to looking at physical activity, considering more of a protective health behaviour. And then I guess this was moving into the school. How can the school as a setting, how can, I suppose, young people thrive in school, not just from an educational perspective, but also in their life in general. And then looking at family and peer groups. So this has been spoken about a lot, obviously, in terms of body image. But we've asked questions about the makeup of your family communication, family mealtime, your peer groups, peer norms, for example, friendship groups, also unorganised and organised, I suppose, leisure activities. And then looking again at country level, so what's happening in different countries in terms of policies and taxations, and is that impacting on child and adolescent health? And I suppose, someone mentioned Brofenbrenner's model, and this has been used, that sort of socio-ecological model of child development, that has been used, I suppose, initially at the beginning to look at child and adolescent health and development. But that's not to say that many researchers with different backgrounds use different theories then as they're analysing the data, I suppose, and trying to test hypotheses, which loads of psychologists love to do, of which I'm not one. So we have this rich source of data, and really, I suppose we feel that we have, an ethical imperative almost to use this data. And in some ways, we probably don't do that fully because we have so much data. But we're certainly in Ireland and in Galway, we're a small team, so obviously working with others really helps us to use the data to its full extent. And translating it into action is really important. So overall, the idea about improving the health of young people, and I suppose coming back to health promotion, which is our discipline and the discipline that we're in, a key goal for us is trying to reduce the impact of social inequalities and health inequalities. So we would often take that angle when we're looking at data or trying to disseminate data, while others might have a different approach. But key to it all, I suppose, is advancing that understanding of adolescent health. And, if you'll recall, I suppose back in the 1980s, growing up as a child or a young person in Ireland is very different than it is today, including in other countries across Europe and North America, where obviously back then we didn't ask questions in Ireland on sexual health. We didn't ask questions on social media, it wasn't such a thing. So I guess this survey, we have to be very flexible and open, and we are. And there, over every survey round, we're adding new questions because that's what's important to children in Ireland. I guess working with young people, which I'll come on to as well, is one of the key ways in which we can do that. So one of the, I suppose, the key things about having this international data is that we can compare ourselves cross-nationally. So that, I suppose, figure over there is showing Ireland just almost at the top, and that's for tobacco consumption. So, often our funders and policymakers are really happy to see these kind of rankings, but there are other times when Ireland is not ranking favourably. But that's a chance where then we can look at other countries to say, what initiatives have they brought in? What strategies do they use? How have they brought about change? So this international data, we do compare ourselves to other countries, but also look, has it changed over time? What about, comparing age and gender groups? Is that different in other countries or the same? And what about the relative socioeconomic inequality as well? So there's lots of, I suppose, value from this international data. And I know the Body Image Research Network is obviously just establishing, but building a network or maybe an international data set, as some people were talking about, thinking about, I suppose, the value of it, it can be very powerful as well. So, so I suppose one thing I was going to say in terms of the data and the quality of our work, so we I suppose, publish, should I say, these international reports. So the last round of data collection was 2021-22. And for the first time, we actually, I suppose, published separate reports throughout the year. So we've published 6 so far, and we have one that's going to come out next week, so everybody look out for that. In the past, when we finished a survey round, we often did one sort of larger international report and maybe focused on social inequalities or something like that. But this time we separated them out. So just to say, the one on sexual health was led by Andras, and I was involved in the physical activity, diet, weight status and body image. It's a really great title, isn't it? But we'll come back to that. So these are the reports, and since those reports we've had over 37,000 downloads. Each volume of those reports has had between 500 and 1,000 media pieces. So great media attention, which, as we know and other people have spoken about, it is a way of getting adolescent health on the sort of the agenda, and where it's been spoken about, listening to it on the radio. Schools or school principals might be thinking about it, parents, for example, but also our partners, our collaborators, but also the policymakers as well. There's been lots of protocol requests as well over the years. So that is, another available resource to anybody who's interested in the survey. And one thing to mention, I guess, is the data browser. I'm afraid to press that in case something goes wrong. So this browser actually hasn't been, I suppose, publicised, but you can look on the data browser on the HBSC International website and look at the data by, for example, age, 11, 13 and 15-year-olds for each indicator that we have. So it's a really quite useful resource, even if school children are doing a project, people in university are doing a project. So there's been a lot of interest in that. And over time we've had, 1,600 peer-reviewed articles in English, lots of articles in other languages, lots of reports, policy reports as well. So I suppose the reason I'm saying this is, it takes time, I guess, to build up this established network, and that it is considered, a place of high quality data. So that takes time, but I guess all of the different types of dissemination helps to get the message out there and helps others to know who you are, I suppose. And so this is just an example of a quote from the WHO Regional Director for Europe saying, HBSC study provides a springboard to set up existing initiatives and develop new policies. And this was particularly in relation to the mental health and wellbeing report, which was launched earlier in the summer, I think it was in May. We got a lot of attention, particularly around declining or poor mental health for adolescent girls, and particularly the older adolescent girls. So here I just want to talk about 2 examples maybe of where the data has been used to impact policy making in different countries, and then we'll come on to Ireland. So the first one is HBSC Germany, and the second one is Latvia. So similar kind of, I suppose, approaches in that in Germany, finding alcohol use was high among their 13-year-olds, and alcopops was widespread. So they introduced a tax so that the price of alcopops obviously increased. And these revenues were also used for alcohol prevention programs, which is quite nice, which doesn't often happen. Certainly some of the sugar tax, for example, here in Ireland is not used for the same reasons. And then the data, again, in subsequent survey rounds showing a decrease in alcohol. So it's very impactful for policymakers as well to show actually this legislation does work. So similarly in Latvia, and the Principal Investigator in Latvia talks about this at many meetings, bringing in a tax on sweetened drinks, moving that forward again for a tax on what's sold in or a ban on what's sold in schools, like your soft drinks, sweets and salty snacks, and banning the sale of energy drinks. And I think in Latvia they may not even ask about energy drinks anymore because up to 15 years of age it's banned, they can't buy them. So again, it's just example of how our data can be used to demonstrate a change is needed. Legislation is often a way to bring about this change, and then I suppose the supporting evidence to show it's been effective. So if I move on a little bit so this is one of our network meetings, and just to talk a little bit, I suppose, about our interdisciplinary working or working across disciplines and how it brings challenges and opportunities. So a lot of the opportunities are looking at that cross-national data, looking at what's happening in other countries, but it can also bring challenges as well. Here, just in this slide, I've just wanted to, I suppose, describe how we operationalise the network because it's so large. So we have an international coordinating centre, an international data management centre, both of which are in Bergen in Norway. And then each principal investigator in each country would meet and can vote on certain things in an assembly. And just to note, I suppose, the principal investigators in each study, they're responsible for securing the funding in each study. So there's no funding centrally from WHO, for example. There may be for some countries who are joining initially, but not for, I suppose, more established members. And then we have a coordinating committee, and there are chairs of each of these groups on that committee, and they advise the PI assembly. And then we have other groups as well. So I just mentioned the focus groups. So as you can imagine, we have so many different disciplinary backgrounds, and people are interested in certain topics related to child and adolescent health. So we have a focus group, sexual health focus group, eating and dieting focus group, a school focus group, peer social focus group. And the idea is they meet at our network meetings to kind of drive forward what new questions need to be asked, or how do we need to look at the data slightly differently. And we might have shorter term working groups as well, so we'll come back to that around maybe measurement of sex and gender, which Andras also led out on for the network. But in terms of interdisciplinary research, obviously we recognise we have disciplinary differences, and that's both in kind of research practice, in culture, but also how we might communicate with each other, and also in the theoretical frameworks we might use. And certainly when I joined the network originally, which was way back in 2005, and I initially joined the university as a postdoctoral researcher, you know, I was embedded in nutrition and what that is, and less so even in health promotion, which is a much broader outlook. So a lot of jargon was being used. I was sort of had to sit and listen probably for the first couple of network meetings before coming used to, I suppose, practices and culture. So it can be challenging because, as others have said here, you're particularly interested in one way of working, but how do you work in another way? So what about the sociologists and how they may work, or epidemiologists and how they may work, and how do we do it together? Bearing in mind this is a quantitative survey, but that doesn't mean, obviously, a lot of the background work is piloting items, qualitative work with young people as well, to enable to have this large, I suppose, quantitative survey to be rolled out. Other things, I suppose, with the cross-national network, you can imagine lots of differences in terms of the politics in different countries. Culturally, they're very different. And so we have to, I suppose, work together and in some ways reach agreement. It may not always be a consensus, but, you know, an agreement on how to move forward. So just thinking about some of the challenges we've come up against, thinking about sexual health, as I said, many years ago in Ireland, we didn't ask questions on sexual health because the schools were like, absolutely no way. If you ask a child about their sexual health, that means they're going to engage in sexual activity. That's the idea. And similarly, we've had that with body image questions as well. It's been just remove the body questions on body image and then we'll administer the survey. And I suppose just recognising how, I suppose, our world has changed, and in Ireland we've had dramatic changes as well. But cross-nationally as well, you know, what is a family is considered very different maybe in some countries over others. So is that a traditional family, which might have been a mother and a father, and actually makeup of families has evolved and changed so much, but some countries, you know, less willing to, I suppose, look at that, or ask questions that might capture different family makeups. And similarly about questions on gender. So traditionally we would have had a question, are you a boy or a girl? Seems straightforward enough. And we've used that for years, and we in Ireland used to present that by gender, used to say. But then I guess recognising that, you know, what is that actually asking? So is it gender or is it sex? And then also, is it not, I suppose, inclusive of other young people? So Andras led out in, I suppose, leading some work looking at how do we change our questionnaire that it is more inclusive. But actually some countries are not willing and not open to including questions on gender identity, for example. And not because they may necessarily not believe it, but they know it won't work in their country, it won't be funded, or their schools will not let them in. So I guess the reason I'm putting up this example is, you know, it takes time to see change, despite the fact that we might feel it's, you know, I suppose best practice or good for research. It may not be practical for some countries or in some schools or some regions. And another example is similarly is around youth participation. So I chair the Youth Engagement Advisory Group. So people have talked about PPI and involving young people. But I guess when we were initially bringing in youth participation into the HBSC network, there are many countries who were like, what are you talking about? Why would you bring a young person? We're the scientists, we know what's best here. But that has, over time, lots more countries are now leading out on youth engagement. And an example, in Ireland, for example, a number of years ago, we had a large project involving young people from around the country, and really they revamped the questionnaire for us. And the kind of overarching question was, what's it like to live in Ireland as an adolescent? And that's how they sort of identified topics, thought about we should include, you know, something else on individual autonomy, for example. The younger children wanted to ask about love and their families. So a real broad range of topics, some of which were not fit for a quantitative survey, obviously, and some were. And then, I suppose, coupled with that is we can have, I suppose, conflicts across the globe. So whether that's, you know, through climate change and challenges within countries who may not be able to collect data, but also war, obviously. So more recently, with the Russian invasion of Ukraine or Israel's invasion of Gaza, this has created a lot of conflict and challenges working across the network. So there is no solution necessarily here, but this is, I suppose, just to try and, I suppose, give a flavour of what it's like. It sounds, you know, and it is amazing to work across nationally, but it's not without its challenges, I guess. And I suppose just to say, you know, these differences, that sparks debate, but it sparks also reflection and new ways of thinking. And at the end of the day, we always kind of try and bring it back to the principle of, well, how are we improving adolescents' lives, essentially? So that's the primary goal. So bringing it back to that. Okay, so I'll just move a little bit on to the Irish Health Behaviour in School-Aged Children study. So similar to the international study, it's, you know, we're looking at context of health, risk and protective behaviours and health outcomes. Just to point out here, I suppose for many years we've involved young people in the survey, right from deciding what questions should go in to helping us then disseminate that information. But we also have what we call an integrated knowledge translation approach. So some people might be very familiar with knowledge translation strategies and frameworks, and some may not. So I'll talk a little bit about that. In Ireland, we also collect data, do I have it here yet, from children in 3rd class up to 5th year. So we actually have a broader age range, so children from as young as 9 up to 17, 18 years of age. And then we only submit the data on 11, 13 and 15-year-olds to the international data set. So we have much broader age range in Ireland. So internationally we have what we call mandatory questions, so everybody asks the same questions, and that's why we can have cross-national comparable data. But we also have optional questions, so if you're particularly interested in body image, we may only have one mandatory item, but we have optional questions as well that some countries can include. And then we have national specific questions, and this is actually our opportunity to engage with our community, our charity groups, with the government as well, because they will say to us, please include a question on X, we do not have any data, and I'll come on to that. So that's just a little bit about the Irish study. So in terms of knowledge translation, I suppose the primary goal of knowledge translation is we're getting that data. People talked a little bit about actually using your data, or getting the findings into the hands of those who need it. So is that schools, is that policymakers, anybody that are what we called our end users, somebody used that name, or we call them knowledge users. So we have I suppose when you're thinking about a knowledge translation strategy, and I'm not sure if many people use this in their research, but it might be something for the Body Image Research Network to think about. So what is the knowledge, or what is the message you're trying to get across? Who's going to do it, or who's your partner in doing it? What's the end goal? Is it about facilitating change, or is it about creating awareness? Who is your knowledge users, I suppose, as well, and who will help you share that? And how will you deliver that message? So some people have talked about, not just the peer-reviewed journal articles, and it's the same for the HBSC Ireland study. We do need those journal articles, but we also have short reports, infographics, respond to consultations that come out, respond to data requests. What else? We have fact sheets. So lots of different, I suppose, mediums to try and disseminate your information to the various different audiences. So thinking about a knowledge translation strategy from the beginning can actually force you to plan and then implement a strategy, rather than thinking I'm at the end of my project now, what am I going to do? And I suppose just for anyone who might be interested, there are many knowledge translation frameworks, strategies and approaches. So this is just one. But I guess what's important here just to note is it's not just the knowledge and who you're trying to deliver it to, but if it's not working, why is it not working? So looking at that and trying to evaluate your knowledge translation strategy. And so that can be quite important, because you may change your approach for the next time. And lots of people do their PhDs in knowledge translation work, so for anybody that might be interested in that. And there's also lots of planning templates for knowledge translation. So these are developed that can be just for research or non-research projects as well. So that's just an example of one from the Hospital for Sick Children in Toronto. So that's quite a simplified one, but there are many others that you can use. So having this integrated knowledge translation approach, it might be very familiar to some of you, but if not, it could be something to think about for the network. Okay, so a few examples in terms of research impact. I guess just to again come back to improving children's lives at the bottom there. I mean, that's I suppose a principle underpinning our work in HBSC Ireland, and we've often, I'm looking at Andresh there, come back to, okay, well, will this piece of work improve children's lives, or should we focus on something else? Because there are often conflicting sort of tasks and timelines as well. So the approach then to impact policy is we obviously need this high quality data. We also obviously need to try and encourage use of that data in policy, and collaborating and communicating with our advocacy partners. So the reason I have that there is, for example, we did some work with Family Carers Ireland. So that's a charity group trying to support carers in Ireland, but also including young carers. And we do have a question in the survey asking if young people are a carer. So it might be that they're caring for a family member who is disabled. So they may be spending more time at home than in school, or not able to do their schoolwork, or not able to hang out with their friends. So all of these things can influence that young person's life and their trajectory. But by engaging with Family Carers Ireland, and doing a short report for them, they also use their networks to disseminate the information, to get the message out about young carers, and they need some more support. And they did some advocacy work with the government around needing more funding as well. So that's just, I suppose, one example of working with your, I suppose, community groups or advocacy groups, and they then can push the message forward further as well. So how do we impact policy making? So when we're thinking about the next survey round, which for us will be in 2026, 25, 26, yeah, if we're successful getting funding. But before that, and obviously we've been doing the survey, you know, for a number of years, we're engaging with policy, with public health, with voluntary groups, and asking them, you know, what are the gaps in data? So they're coming back to us. This is long before we've agreed on what our survey is going to be. And we also have a research translation help desk, so they come to us and ask us for data or short reports on different topics. As I mentioned, we co-designed the research with young people, and we continue to do this. And I think that's, you know, obviously it is important, but continuing to do it is obviously also important because their lives are changing all the time. So just examples of, I suppose, policy interest and policy areas. So the sun safety behaviours, I'll come back to that, and interesting that you were talking about skin cancer. But areas in terms of sexual health, gender identity as well, or period poverty. So we've no questions on or a sense of period poverty among young people, and the Department of Health and the Institute of Public Health were very interested. So we've included a question on this. So we do have a measure of it. The same with smoking in cars. A number of years ago, we included a question just in one survey round so that the government would have some data and then could introduce legislation. And similarly with vaping, we've included a question on e-cigarettes or vaping in the 2018 survey round and again in 2022. And that data is being used to advocate for, obviously, new legislation coming in, but also for further measures as well. So just in terms of sun safety behaviours, the Institute of Public Health approached us saying we don't have data about young people and what are they doing in the sun, how long are they spending in it, are they using sunbeds, sunscreen, etc. So Andras also worked on this. And there weren't questions either, so we had to go out and try and pilot some questions, and then these were included in the 2018 survey and again in the 2022 survey. So we're continuing to work with the Institute of Public Health on this to work further on the data. But that data was used within the National Skin Cancer Prevention Plan. But if anybody has primary school children, a circular went out to primary school parents as well around the importance of, you know, wearing long sleeves, a hat, sunscreen, etc. And some of that was coming from our data. So I think that's a good example because, you know, when you think of child and adolescent health, people often don't think about out in the sun and or sunbed use as well, which is obviously of concern. So other examples where our data have been used is developing the public health alcohol bill. I mentioned already tobacco and vaping products. More recently, the Institute of Public Health and the Department of Health were interested in girls' health. This is related to the Women's Health Task Force. We did a specific report on girls' health, and then together with the IPH, they put in data back into the Women's Health Task Force to show that we do need, I suppose, supports and campaigns and initiatives and interventions for girls in particular. And I had mentioned about some of our questions that young people themselves had formulated and we put into the HBSC survey. Some of those are actually used now in BOBF, which is the Better Outcomes, Brighter Future framework for children and young people, and indeed Young Ireland. So our data are used as national indicators to show whether strategies are working for government. But all of these things have taken time, obviously, to develop and to bring about change. So on our HBSC, on our University of Galway website, there's a little a piece there about how we've involved young people. And some people may be familiar or may remember the Changemakers TV programme, which is probably now 2 years old. But again, it's on YouTube, you can watch it. It's looking at research on children's health and well-being from universities around Ireland, and every episode focuses on something else. But the reason I suppose I'm presenting it here is to take those opportunities as well to get your message out there. It's just another medium for people to be aware of the HBSC study, and also for us to be able to recruit schools. You know, if they're watching something like this and they hear about the study, they may be more willing for young people to take part. Because as I've been talking to some of the delegates saying, in 2022 it was one of the hardest years to recruit schools. So it's getting more and more difficult, I think. So just in terms of maybe, I suppose, key messages, it's about making it count so that your data or findings are publishable and findable. I think that's, you know, building that profile, that expertise, building confidence in your data. It has to, you know, to have meaning, it has to be findable, I suppose, as well. To share it, open access if at all possible, but, you know, getting out there in terms of media, access to the data, etc. And as other people were saying, we need some of those formats that make it just so digestible. It's easy for a policymaker to have one line to say to the media, and that can have impact. So we're still working on, I suppose, for, you know, making it easier to use our data. I think to use our findings. We're still working a little bit more on that. So finally, on body image, and then I'll. As I said, we have national questions. So we have one question here on, do you think your body is? And again, this is all self-report. And this is more related to, obviously, body weight, shape, rather than body image more broadly, which some of you have been talking about today. So they're asked, do you think your body is much too thin, a bit too thin, about the right size, a bit too fat, or much too fat? So Andras presented a little bit earlier today. We do have, as I said, that we have optional packages. We haven't collected this data in Ireland. There's a question on perceived appearance, which is about looks, as in good looking, and then feelings about your body. So agreeing or disagreeing it's a 6-item scale around frustrated with my body, those kind of things. It's about physical appearance. But, you know, if people are interested in this and feels it's important and feel we should include it in the next survey round, you know, please get in touch with us, because this is the way how we build collaborations and how we can use the data more thoroughly. And other countries do use these optional packages as well. There's obviously limits because the questionnaire cannot be too long, but we have to weigh up the pros and cons to different questions. So in 2022 in Ireland, we did have over 9,000 students take part. We did have to weight the findings for gender and regional imbalances. So just to say that before I show the body image data. So about 47% saying they're about the right size. And you can see there the proportion saying, you know, much too thin, a bit too thin, etc. So that was for our 5th class to 5th years. But again, what we can see here, which is no surprise, that the girls more likely to think that they are too fat, and this is increasing with age. So again, it's not surprising, I guess, or not a surprise to you. But I guess, you know, I suppose cross-nationally, the data for this question has been used looking at trends. So it's a cross-sectional survey, so it's different individuals over time, but how the proportion of, I suppose, adolescent girls who report to feeling too fat is sort of staying consistent, but actually it's been increasing for boys. So it's something that we should, I think, relook at again. And people have talked about, I suppose, boys' body image and muscularity a little bit today. So we have some missing data as well. So that just gives you a flavour, I suppose, by age. It's nothing astounding or anything. In the international report, I said we do have questions on body image, and we're calling it body dissatisfaction again. It's related to that self-perceived, I suppose, weight and shape. Again, cross-nationally, so this is again 11, 13 and 15-year-olds. Girls more likely to think they're too fat, and this gender gap increases with age. So it's just another way to show I suppose, the data. So higher among girls than boys, and also that says low affluence and high affluence at the end as well. We do have self-report weight and height. In Ireland, we don't actually use this data because we have such high missings. But cross-nationally, from our data, from the self-report data of weight and height, more boys would be calculated to be overweight, I suppose, but more girls think they are too fat. I suppose, again, that's not too surprising. So, in summary, I suppose, just reflecting on the network, it's long established now, but we're still evolving, and we do still have to adapt and be flexible to change, because adolescent lives are constantly changing. We have lots of questions that we haven't spoken about, whether that's bullying, social media use, spirituality, loads of different things, I suppose. So please do look on our website. We do think adolescent health is a very important developmental stage. Many people feel, well, adolescents are generally healthy relative to other age groups, but actually it's a time where things can go awry, I suppose, and we need to invest in it. And we've been actually working with the WHO to try and get the child and adolescent European health strategy back on the agenda, using HBSC data as well as other data sets as well. So we're hoping that's going to be, I suppose, signed off in 2025, so that we have European strategy and then countries can respond to that as well. I mentioned at the beginning an ethical responsibility to use that data, and I truly believe that. So people who are open to collaboration, interested in using some of the data, please do get in touch. We cannot use it all to the full extent it should be used to. Planning and prioritising knowledge translation, I think that has made a difference in terms of our research impact. Placing value, I suppose, on those policy contexts that we do have. But maybe just to end about the influencers. So often the politicians, they move on. Governments are changing all the time in Ireland and other places. And often it's the civil servants or those who are making policy. They're the ones who will be there much longer. So working with them and building relationships with them is really important, as well as your community groups and your those working in charity groups, those who are your advocacy partners as well. So just to end, just want to thank obviously the project team, just throwing them up there. Thank everyone here, but also the children in particular and their schools and parents for actually enabling us to collect data from them. Just to want to thank them. So there are some of our contact details. Sorry if I've run over, and thank you very much.